Hello, I'm Manoj Karmakar. In this next video, Dr. Tony Ng from the University of Hong Kong in Hong Kong is going to be discussing with us the topic of chemical denervation of the hip joint in patients with inoperable hip fractures. If you're liking any of our videos, do remember to like and share these videos with your friends and colleagues. Also, do remember to subscribe so that you can get regular notifications of any future uploads. Now enjoy the upcoming video.
Okay, thank you for the kind introduction from Professor Kamaka, and also thank you for your invitation to this very nice webinar. For me to share my humble experience on a very minority group of patients who cannot go for surgery. I actually want Chris to look at this picture because this is one of my favorite places for me to have cycling actually. So if I have a chance, I would really want to invite him to Hong Kong to have a ride in this nice landscape. So here we go. So this is my disclosure slide. And concerning my scope of my talk, I will talk about the indications in the context of hip fracture. And I will also try to tell our story and journey to develop different approaches of hip neurolysis in the setting of hip fracture. And lastly, I would also like to tell some clinical pros and also practical tips and our outcomes so far. So the clear indications for chemical hemolysis, neurolysis in inoperable hip fracture, as stated in the title and topic. Nevertheless, just want to let you know there are some other good indications that may be eligible to this technique, which would include those advanced osteoarthritis of hip, no matter they are too old for the surgery or too ill for the surgery, or the waiting time is too long, and then the pain cannot be controlled conservatively, or else in those cancer pain patients on those high dose opioid with radiotherapy maximized, and the patient still yell, cannot be ambulate, cannot come out of the bed, and you can still consider this. So why hip neurolysis in the fracture hip here? So usually our cases are those with too high risk for surgery or too ill for surgery, or sometimes now, because this is a standard option in our locality, during the discussion between surgeons and relatives and patients, and when the patient is too old, demented, even without any acute medical insult, sometimes the relatives of the patient still don't want to go for an open surgery for fixing the fracture, and that's why they will go for the hip neurolysis sometimes. And when you try to treat this group of patients, so think about this. Our endpoint is we really need to relieve the incident pain, because this is the most challenging pain we would like to handle. So that would refer to turning the patient to change the pampers, asking the patient to come out of the bed and sit. And this is really challenging most of the time without any good energies here. And in those cancer cases, we would like to reduce the opioid consumption as well. And one of the very important thing here, which is different from surgery or the regional block for surgery, is we really need to consider something that is free from motor and sensory blocks. Low incident, but free from it, because this is very important. Because now we're injecting some neurolytic agent, but not anesthetics. So this is a very important consideration for us. So let's think about those old ways that we have all along, including those traction like this by the orthopedic surgeon on the wall. Of course, it works. Everybody knows it works, but then the patient have to stay here for a few weeks. Then how can the surgeons discharge the patients? And even we don't mention about this logistic problem with the patients become bedridden for weeks. Most of the patients, not most, but quite a few of patients may develop other complications like pneumonia, which is not that good. Oral analgesia, well, I guess most of you, if you have the clinical experience, you know that no matter how much oral analgesia you would give, you cannot really handle the movement pain quite well unless you give some strong opioid. But don't forget this. This is a group of frail patients. If you give those strong opioid, many of them basically cannot tolerate the side effect opioid, and the movement pain is quite breakthrough and incident, short-acting, fast onset. So unless you have a really good opioid that can synchronize of all these stimulations, otherwise basically you cannot match the stimulation there, and you will give long-acting opioid. So when the patient is resting comfortably on the bed, the opioid side effect would be too much. Intranasal fentanyl, it would be a possibility to handle this problem, but basically it's licensed for cancer pain only. So this is not so good. Okay, when I was still a registrar, I learned that I will use some catheter like femoral nerve catheter, or the catheter that Chris just mentioned is the fascia iliacus block. Of course it works. And in fact, we are doing this as well, especially for those who require surgery, but still need to wait for, say, 1 week or 2 weeks more, so that some basic medical problem can be fixed or optimized, or when the patient is put on some anticoagulant because of cardiac stent, you still need to wait for 1 or 2 weeks more before the total course of anticoagulant or antiplatelet is completed. For those cases, we still give a catheter with continuous infusion, and it works really well. But in the setting of those who are not going to do surgery, if you put in a head catheter again, so how can we discharge the patient home? So this is the biggest issue in our locality. I know that in some countries they have a portable pump, and then you can have a very, very strong community nurse who can take care of those catheter and pump. That would be really good. But I'm quite envious for those countries or places who can offer this type of service. But in Hong Kong, this is basically impossible. So catheter option is out for this setting as well. Okay, so and then we talk about why chemical approach. Some people would argue why not doing some radio frequency, which may be more long-lasting theoretically compared with a chemical approach. So there's several reasons for us to use a chemical approach, because one of the reasons is we do most of our cases in broad room or in our PACU. PACU is in our hospital is a hybrid between broad room and recovery area, and we sometimes do our epidural there as well. And that's why we don't have those radio frequency facility in the PACU. And another thing is, remember that this is a group of patients who have multiple comorbidities, and many of them are demented and with some cognitive dysfunction. So how can they communicate with you well for the motor and sensory testing? So this is a big question for me. And comparatively, if you heard from other lectures or read about the literature, if you do a radio frequency, you basically need to have a stacked lesion. That means to have the multiple lesions along those target nerves that Professor PENG just talked about. So it's very time consuming. And of course, radio frequency is quite expensive. Just the needle, it can cost around several $100 or even $1,000, and which is much more expensive than a simple spinal needle or a broad needle. And even with my neurolytic agent, which is also cheaper than the radio frequency. And although you may argue the duration of action of the chemical ablation would be shorter compared with radio frequency. But think about this. Most of the fracture will heal by 3 to 6 months, right? And if you know about the duration of action of alcohol well, most of them also work for few months. So can you imagine this? Actually, the duration of action of alcohol or even phenol can match really well to the healing process of fracture. So that's why it's a good choice in this context. And when we come to those case selection here, so we need to check about first of all the type of fracture. I heard from Professor Peng's talk. He talked about those different types of hip fracture. This is a really important consideration here, because if you talk about those hip fracture, which is actually the proximal shaft of femur, which is too far away from the hip capsule. So sorry, the hip neurolysis may not be a good choice in this type of hip fracture. But if you talk about the intertrochanteric fracture or lack of femur or head of femur, yes, they are good cases. And another thing we need to assess is the pain intensity on movement. Sometimes without a very good reason to explain, some of the patient even they have a very clear fracture there. The patient doesn't feel any significant pain. Even you try to move or rotate or even rock the hip joint. Some of them can be explained by a very small crack fracture, but we do really see some patients who have a very displaced fracture, but then the patient still at most just complain of a mild pain only. So for those cases, we need to balance between the risk and benefit. And for those cases, we may not offer a hip neurolysis for those patients, because there's still some risk that we'll mention later. And before you consider chemical ablation here, we also need to consider other the patient comorbidities. For example, the heart failure, whether the ejection fraction is too bad, any recent tachyarrhythmia. Remember, if you give alcohol, the patient will have some alcohol absorption and will resulting in sinus tachycardia, and which may actually trigger another episode of atrial fibrillation or SVT. Advanced dementia, the patient may become even more drunk. For those with pacemaker and ICD, of course, they're not a good choice for radio frequency. So chemical ablation would be a good one. And we also need to consider those liver renal impairment as well. Some people will ask me, especially from those overseas, whether you would do a fluoroscopy guided or a cuff approach. For those who don't know what cuff approach refers to, it means the combined ultrasound and fluoroscopy approach. So it really depends on your experience and your facility availability. So the pros of using a fluoroscopy is you have a dual modality confirmation. So it also allows you to see the contrast spread before you inject your neurolytic agent in advance. So which is a good thing. But then it takes more time, and basically if you just do a fluoroscopy guided procedure, you cannot visualize all the soft tissue. And there's a multiple studies in the early 2010 show the fluoroscopy guided articular branch injection for those pain patients. It works, but the effect size is not that strong compared with the ultrasound guided. So what I would say is if you have the X-ray, you can still use it, but I would not recommend a fluoroscopy guided only procedure for this neurolytic procedure. So so in our center, we actually use ultrasound guided approach only, because I just mentioned to you, we do almost all our cases in the PACU or in the broad rooms. So what are the approaches we have developed so far? Now, this is our first case report. reported by our colleague, Dr. Sasaki. And we actually did this in 2015 or 16, okay? And then we spent some time to validate and also write up the case report. And also, of course, Professor Pan also supported us in this case report as well. The idea is we try to find about the articular branch by thinking about those pericapsular targets. So, and also we try to adopt the Hilton's law. For those who don't know Hilton's law, it suggests that any nerve serving a muscle that produces movement at a joint also innervates the joint itself and the skin over the joint. So if we know that the muscle here is innervated by the femoral nerve, then there must be a somewhere a femoral nerve articular branch somewhere underneath this muscle before it enters the hip capsule. The same for the obturator nerve as well. So our very initial approach is to is kind of infiltration by infiltrating a large volume of local anesthetic followed by alcohol, and try to infiltrate this what we call now is the iliopsoas praying here to block the articular branch of femoral nerve. And this is the contrast spread. And this which is quite similar to those to the fluoroscopy picture just shared by Professor Ben in the last talk. And another one is from medial to lateral to the underneath the peteneus, and people now call it a subpeteneal praying. And we also inject another volume here. And the spread of contrast is also correlated with the what we call it, the inverted vase, the inverted teardrop side in the fluoroscopy approach. So this is after we do this, the Danish group actually probably something to support us in terms of the iliopsoas spring block. They invite 20 patients to volunteer to inject some LA and also some MLI contrast, and then they inject to the same plane here. And then you see most of the contrast spread will be limited by iliopsoas tendon, and basically they will spread around this iliopsoas spring that block the femoral articular branch as well as the accessory obturator nerve. And then another study from the same group of researchers from Denmark. This time they try to use the cadaver to validate the subpeteneal approach, the subpeteneal injection. Again, they use 15 ml here, methane blue, and they found that apart from the articular branch, it also brought the main branch of obturator nerve as well. So this gave us some additional information that, oh, this approach, although it worked really well to block the articular branch, but it may have a chance that it will affect the motor branch of the obturator nerve as well. And that's why another thing is for this infiltrative approach, because we give a big volume of alcohol, most of the patients become so drunk. Many of them were very sleepy afterwards. So after we did 2 to 3 cases, we modify our approach, and we also got an opportunity to discuss with the Toronto group, of course, led by Professor Pan, and we modify our approach, and we have a journey that we use the Pan block approach plus the obturator nerve articular branch approach, but we use a much lower volume. But then right now, at the moment, we actually combine all these 3 approaches all together. So why? Because for the pen block, we can handle the femoral articular branch, high branches, and accessory obturator nerve. And we still do the iliopsoas spring block infiltration, but use a much lower volume our aim is to cover the low branches of femoral left articular branch. And for the obturator left articular branch, it really depends on the patient's position. I will elaborate later. We will do the classical oblique approach, or we develop a sagittal approach as well. So just to recap the PENG broad approach. So this is just using a curve or a linear probe, depends on the body build of the patient, and then use a lateral to medial trajectory, and then you inject a low volume of local anesthetic. We use in our hospital, we use 4 to 5 mil, or if sometimes even 3 mil of local anesthetic. So we really mandate us to have a really good lifting of the iliopsoas fascia, so that we use a very low volume of local anesthetic, you can still block these articular branch well. And then we follow with followed by the same volume of the alcohol, absolute alcohol injection in the ratio of 1:1. And for the obturator left, the initial approach is the classical approach. We move down from here after we visualize the head and leg of the femur, and then we move down until we visualize the inferior medial acetabulum, where the femoral head will disappear, and then we inject 1 to 2 cc of local anesthetic, followed by the same amount of absolute alcohol. But for those who have done enough cases of hip neurolysis, you will encounter that real life is not so simple and easy. So for example, this is a case that I did last week or this week. You can see the AIIS here. There's a lot of osteophyte here. So you can basically see double shadow here. Even if you move down the probe a little bit caudally, it's already the head capsule. So you can also see there's a lot of bony irregularity here. So this would give you some challenge that you may not faithfully inject your local anesthetic or alcohol or other neurolytic agent evenly enough along this what we call PENG plane. So we cannot guarantee this. Another thing is, this is the hip capsule or the iliopsoas plane. This is the hematoma. We have some real cases that the fracture was too bad that when you try to move the probe caudally to look around the capsule, that the Danish group demonstrated in the cadaver study or the volunteer study, basically it doesn't work because there's a lot of destruction of the capsule as well as hematoma sometimes. So how can you identify the capsule clearly here? So again, is another challenge. Lastly, for those who did the obturator left block, I also heard from our local anesthetists, also PENG physician, to feedback to me that they quite often encounter this problem because many of the time the patient's hip is external rotated when they have a hip fracture. This is most of the time is their lateral position. And when you look at here, the femoral vessel will actually be twisted laterally and also deviated laterally. So you cannot see a very oval shape of femoral vessels here. Instead, it twisted here. And this is actually the trajectory of your needle towards the IMA. So this gives a big challenge for us to perform the ONAB neurolysis and block. So how do we handle this? So think about when we talk about the ultrasound, this is a 2D image. If we turn the probe from here to 45 degrees, so that is in a longitudinal way, and then we shift the probe medial to lateral very slightly and meticulously until we see this image. So this is another view of the inferior inframedial acetabulum, and this is also the peteneus. And very surprisingly, sometimes you can see some honeycomb-shaped nerves here, which would correlate with the obturator nerve articular branch that Professor Pan just talked about in the cadaver finding in the last talk. So that would suggest that this approach, you may visualize the nerve, and secondly, you can basically avoid the vessels. When you shift the nerve to, a little bit laterally, you can see the whole vessels here, so that you can really avoid it. And because the needle trajectory is from caudal to cephalic, so theoretically your needle target is more close to this articular branch. If you can see the nerve, you can basically just put the needle here and you're injected directly to the nerve as well. And think about another consideration is if there's a femoral head or femoral leg fracture, if the degree of fracture or the destruction is too severe, basically you cannot identify any femoral head here. So it will be of some challenge for you to identify the IMA clearly, because you don't have a femoral head for you as a guide. But if you use the sagittal approach, you basically avoid this problem. So this is the beauty of this approach. But my practical tip is, I would say 90% of the patient nowadays, I would use this sagittal approach to target the ONAB, just like this patient. However, very occasionally, we still encounter patients who have hip fracture in this position. I had a case I did this week is in this position. So you have no way to target the pubic bone or the femoral groin area. In that situation, what you can do, you still need to go for the classical ovary approach to target the ONAB. So this is some ultrasound scan of the world patient to see how I do our anterior hip neurolysis nowadays. So this is the first injection to the pen plane, and then we move down the probe a little bit to the iliopsoas plane here, and then inject local anesthetic, about 3 ml of local anesthetics, followed by the same volume of alcohol here. And then we go for the sagittal approach of the to target the obturator articular branch here by injecting 1 to 1.5 cc of local anesthetic, followed by the same volume of alcohol. So this is the schematic diagram of how I do for the these few injections here. So I skip this because Professor Pan has mentioned this already. This one basically is more related to anesthetics, but for pain neurolytic procedure, we seldom use such a big volume because we know that they will go through, open up all the facial plane channel and go up to the motor branch. And that's why we use the lowest volume possible, so that we hope to keep all the neurolytics or agent just along this plane. So the magic cutoff so far is 20 ml. So remember this number. Don't give anything more than this number. So how about the outcomes? So this is our case series that published in 2020. And actually the cases we recruited were from 2017. And basically the most striking result here is we found that half of the patient could sit out within 5 days after the neurolysis, and more than half of them can be discharged home up or to the OH home within 2 weeks. And very amazingly, 3 of them could actually walk with stick during our long-term follow-up in the orthopedic clinic. And now this is one of the patients who consented me to share his video and photos here. So we try to, this is from day 5 after the neurolysis, and these are our pain nurses. Now we try to press the hip, when you look at the patient's face, she actually felt quite comfortable. And then we try to gently rotate, externally rotate, and also internally rotate her hip. You can see her face is also quite comfortable as well. She actually reported that very mild pain while we try to rotate the hip here, but low pain when flex the hip. And finally, we simulated the usual nursing care to change their diaper. So the patient didn't yell. If you neurolysis, these patients usually yell and very loud in the ward, and even the ward care staff basically didn't have other way to handle this kind of pain. You can also see she could sit very comfortably on a chair, and this is actually what our orthopedic surgeons want to see, because with this, it can largely reduce a lot of complication as a result of long-term bedridden status, and basically can send her home. So, but then, as I said, real life is not so simple. So when we do enough cases, we have some cases that no matter how good we do for the anterior neurolysis for those 3 targets, some patients still yell. And don't forget, this group of patients, quite a few of them are demented, and even you still have a little bit pain residually, they will still yell and scream whenever you touch them and turn them. So when we encounter this, we need to look for this as a differential diagnosis. First of all, whether it's your technical problems. As mentioned by Professor Penn, intramuscular injections is a very common mistake. And whether your fracture is too displaced, that it distorted your capsule too much, or it impinged on some soft tissue, and whether you pick a wrong case for hip neurolysis, which is actually a femoral shaft fracture instead of the hip joint fracture. And I also encountered a few cases, okay, that the patient yelled, but then when we check very meticulously, is the pain from the OA knee and also the contracture, but not from the hip. And lastly, we need to check whether there's any other soft tissue injury like hematoma, tendon rupture, muscle tear, which can also contribute to significant pain. But what else can attribute to this pain here? So I believe that Chris and also Popan have mentioned this posterior hip capsule innervation. Actually, this is the first study who illustrated the significance of posterior hip capsule innervation. This is from the French group. Although we know that most of the nociceptor concentrate to the anterior articular branches, Pierre and his group found that under certain situations, the nociceptor density is still the highest over here among all these posterior articular branch, especially those nerve to the QF and also the superior gluteal nerve and those sciatic nerves. So our question is, how do we target this if we have this piece of new information? So should we target these superior gluteal nerve here, but then you will also block the and neutralize the motor branch of superior gluteal nerve and resulting in gluteus muscle atrophy? And how about this nerve to quadratus femoris? The same rationale here. First of all, it's too close to the sciatic nerve. There's a high risk for you to puncture the sciatic nerve, and at the same time, there's still a motor branch that innervate the quadratus femoris here as well. So they are not a good choice. So our concept of pericapsular innervation can actually be applied to everywhere. Now you talk about knee and shoulder, and here we think about this. So from the diagram, you see almost all the posterior articular branch enter the joint over around this superlateral aspect of the posterior hip. So would it be a good target for us to anesthetize or to lyse the posterior hip capsule? So let's see another discussion here. So people would say the anterior capsule contribute to say 90% or even 95% of the nociception. And then although the last study say the posterior capsule still have some nociception, but then you may say 5 to 10% at most. But how come in the reality, even I block my anterior articular branch perfectly, the patient still yell and the pain doesn't reduce significantly? So think about this. Apart from the reason mentioned by Propan in the last talk, another reason for us to think about is the capsular distortion. Remember when there's some fracture here, just like this CT scan, you see the whole geometry of the joint is distorted. So when you think about this, even without the sensitization of those silent receptor, just the distortion of the capsule can also give you quite a lot of discomfort. So that would be another reason to explain why the posterior capsule can hurt so much when there's a combination of factors, when there's a hematoma, inflammation, distortion of the capsule. All these can contribute to the final nociception. And that's why we try to do this as a PHPN. And we try to locate this because there's a many way to target the superlateral part of posterior hip capsule. But one of the reasons we use this approach and use the piriformis as a guide because it's easily found. It can be reproducible by many patients, many physicians, and it seems to be a easier technique compared with other approaches. And then we also use a medial to lateral trajectory so that most of the injectate is going laterally is instead of going medially, so that the chance of involving the sciatic nerve will be minimized. And then we also use a very low volume, just 1 ml. We see a little bit of local anesthetic or alcohol just spread underneath the piriformis, and then we stop. And then these are the results. We started to perform this technique in mid-2019, and then we gathered the result till the first quarter of the 2021. And then we did 70 cases there. Actually, we should do more, but because of COVID, we did less. And 70 patients responded quite well to the original anterior hip neurolysis to the anterior 3 branches. But then we have around 30% of patients who didn't respond quite well. And then we add the PHPN to these 30% of patients. And then very presently, we saw most of the patients responded quite well after adding the posterior hip capsule neurolysis here. But you still got few patients who still didn't respond quite well. But then this also gives us a information that the combination of anterior and also posterior capsule can compress the PENG generator in most of the patients. And after the neurolysis, as a clinicians, we often focus on our postoperative surveillance, and especially for this group of frail patients. So we need to assess the patient on pain and also functional aspect, but then we also need to look for any potential complications. For example, any groin hematoma. The most risky part is the medial 5 of medial fibrosis because there's a acetabular branch of obturator artery just underneath the ONAB. And that's why there's a risk that you may puncture these small vessels. And remember that many of the patients here, the soft tissue over the medial fibrosis are quite less. And basically the hematoma can be collected without notice there. So that's something for us. It's our routine to look for the groin hematoma after every neurolysis case of our PENG nurse on post-op day 1. Another thing is the hemodynamic instability. There will be 2 potential causes for this. One is the alcohol, because the absorption of alcohol, especially if you have some hematoma there that you are unnoticed, or there's some capillaries that you are unnoticed, and then you still inject your alcohol there, then the absorption will be quite fast. And then there will be some development of groin hematoma as well. And the risk would actually be more if your injectee is more than 10 mil. So it doesn't mean that after 10 mil, all these things would must happen, but just be cautious when you inject more than 10 mil of absolute alcohol. In those susceptible cases, we will give a cardiac monitoring for a few hours to 1 day to make sure the low tachyarrhythmia there. And according to our experience, most of the patient would become stable, okay, after a few hours. And the next question after this newly published article is, do we still need a diagnostic block in the setting of inoperable hip fracture, given that now we know that 70% or even 80% of patients would respond well, okay, to our neurolytic technique. Now, this is just my thought, okay, and basically, if you still your facility or your hospital just have absolute alcohol, so you're gonna give a local anesthetic anyway before your alcohol injection. So you can use this to serve as a diagnostic block, to wait for 10 minutes and then 10 to 15 minutes, and then you try to move the patient so that you know your block works well, and then you give your alcohol or to nebulize the patient. But what I would say is we probably don't need to send the patient to have 2 separate sessions between the diagnostic block and neurolytic block, given that these patients are frail, and it's also quite cumbersome to send the patient twice. And you know that the successful rate is also quite high now, so that probably you just need 1 session for that. So if you have phenol here in your locality, in fact, in my hospital, I'm trying to introduce phenol to replace alcohol in this particular context, because we know that the successful rate is 70 to 80% now. So basically, we may just give the diagnostic block directly and give the phenol, in a sense that it could also give some comfort to patient without the burn sensation. And if you really use phenol, possibly aqueous space would be better because the spread would be better. So and another setting, hip joint bone metastasis, probably you don't require diagnostic block as well. But for OA hip, it's a bit tricky, and I would say we probably still need 1. And lastly, I would like to talk about the future role of hip neurolysis. So right now, we got this technique or treatment modality is palliative. Surgical fixation is still the first choice whenever possible. But in fact, we are now working with our orthopedic surgeons to analyze our long-term results to around 5 years and see any survival benefit in any subset of the patient. For example, for those with acute medical insults, say ACS or CVA, acute stroke, or acute COPD attack, whether there any survival benefit, or there's another group of patients, they are some chronic illness, they are quite advanced but quite stable, like end-stage renal failure, gold stage 3 COPD without any attack, or New York Heart Association class 3 or 4 heart failure patients. So we are trying to analyze our result and see whether survival benefit there. So future directions, we need to explore the optimal volume of our neurolysis technique, especially for the PHPN, because it's a relatively new one, and we understand that our case node is not enough. Okay, we just did 20 cases from the study period. We definitely need a RCT for further validation as well. We hope we can try to look for any survival benefits. Okay, and finally, with further information to evolve in the future, we hope to work out a best practice for treatment choice in fragility fracture in long term. Okay, thank you.